This conference will now be recorded.
So welcome everybody to a special presentation prior to the regular low intermediate support group that we are running today, May the 12th, Monday, May the 12th, and it will start in about 45 minutes. We are really delighted to have the founder of MiraDx and other organizations, which we will learn about, who make a bunch of tests, including the Prostox tests, which several of you have heard about. And Ancan first heard about, I think, about 4 years ago. I would say around 21, sometime around then, we first got word that UCLA had this great test that you could figure out how sensitive you were to SBRT. And we also heard at the same time from, actually, I think it was probably the same person who happened to be MSI high, that you also had a test for checkpoint inhibitors. And I think he took that test as well. And so you have been on our radar for a long time. And then I had the very good fortune to listen to a presentation from Dr. Joanne Weidhaas about a month ago. And since I know that Dr. Mark is really well connected at UCLA, I said, Dr. Mark, we need to get Dr. Weidhaus here and to talk to us. And that's what we're doing tonight. So with that, I will show. Oh, I forgot to say I'm Rick Davis. I'm the founder of Ancan. I am passing it over to Dr. Mark.
Okay, so when I was diagnosed, the first thing I wanted to know was make a decision between radiation and surgery, and side effects come into play. Living in Atlanta at the time, SBRT seemed amazing, and the concern was, what about side effects risks? I saw some papers and suggestions that it might be increased and some that it might be reduced with that. And wouldn't it be great if we had a test that would help us look at our genetics and make smarter decisions regarding our risk of having side effects and potentially come up with alternatives that might provide better results. So we're here to learn about that from Dr. Joanne Weidhaas, a co-founder of MiraDx. She is a professor at UCLA and also a dog lover, as I understand. She leads translational research in radiation oncology, and her pioneering research led to the co-discovery of the KRAS-variant, a strong predictor of cancer risk, tumor biology, and the treatment response. She co-founded MiraDx and MiraKind to empower individuals to have the health information they need to make these decisions. Joanne completed her oncology training at Memorial Sloan Kettering Cancer Center and previously served as the chief of breast cancer radiation service at Yale Cancer Center. She completed an MSM at Stanford University during a sabbatical at Yale and moved to UCLA as professor and division head of translational research. In 2014, her dual role as clinician and researcher applies genetic breakthroughs to patient benefit. She currently resides in LA with her husband and 3 children. Joanne, thank you for coming tonight.
Sure, my pleasure. Thanks for the invitation. So I'm happy I have some slides that I can go through, and please feel free to interject just to give you kind of more of a background, and then happy to kind of answer questions again during the presentation or afterwards. Let's see. I have to ask you to let me share my, looks like now I can. Let's find my talk here. Okay. You guys all can see that?
Yes.
Perfect. Okay. So feel free to, as I said, to interject. So as you got from that nice introduction, I'm a radiation oncologist. I'm a cancer doctor. And as I tell people, I was really perplexed with training where as a radiation oncologist, you see every type of cancer, people of all different types and shapes and different cancers. And I was really puzzled and frustrated by our inability to know how people are going to do with our treatment. First off, there's the whole puzzle of who even gets cancer. And, obviously you guys know lots of super healthy people. But I was also really stumped by why people would respond so differently. And I will tell the story of kind of how we started this company and what our focus has been right now, which we've started with prostate cancer, which is very relevant to the group. So you've heard a little bit about me. I'm currently at UCLA as I'm a physician scientist, a radiation oncologist. My co-founder is actually Frank Slack. He discovered the first example of microRNAs, which are a very new understanding of genetics. Strangely, Frank and I did our PhDs across the hall from each other at Tufts. And we knew each other, we were friendly, but then we ran into each other again at Yale. I was new, and he was a established, successful developmental biologist, and we started working to apply this new understanding of genetics and cancer. And so through that, we founded this company, MiraDx. We co-founded it, and our real goal was try to get this new understanding of genetics to patients that it could help. Frank is, as I said, a brilliant developmental biologist, but isn't a cancer person, and really wanted to get this to help cancer patients. He's very familiar with it, and so together we've made a great team. And our approach, once we discovered these markers, is really different, and I would say consistent with what I thought we should be able to do in cancer. So, the way it's been done for decades is someone will look at a person's cancer and they'll say, okay, it's a lung cancer, let's look at this marker. It's a breast cancer, let's look at estrogen. It's a prostate cancer, let's see if it's androgen sensitive or resistant. And they use something from that tumor, and then they develop a treatment for that patient. But, what was really obvious to me seeing patients was that a patient really brings themselves in the response to treatment. So it's not about the cancer, it's about the patient. And people respond really differently. Even people with the exact same cancers, or they look the same, can have opposite responses to treatment. So that has to be something the patient has. So that has to be in a patient's DNA, not just the tumor. And a lot of the work had been looking at how the tumor was different than the patient, not really just looking at how the patient was different from other patients. The genetics we found really seemed to help us be able to identify the differences people walk around with them that make them unique from each other. Our first test, which I'll get a little bit more into, and I'll talk about some of our other tests, with this knowledge that, hey, we found this new understanding of genetics that could give us some answers. What are the answers that we need to find? There's so much work going into, you have this type of tumor, let's develop a drug, let's develop a treatment, and that is all really important. But I felt like something that was very much not addressed were the different side effects people would have from the same treatment. So, and that is just not a part of the conversation, and it hasn't been. Now, I will pause to say, as a radiation oncologist, we talk about side effects all the time. As a field, we've really focused on improving how we give radiation to help avoid side effects in patients. And we do that by really focusing in and applying new technology that lets us try to focus on the tumor and touch less of the normal patient. And that's done great things over the last 100 years. But even patients treated with the most high-tech approaches still have side effects. So it seemed like a great application of these markers. And, I'll talk a little bit more about our first test in prostate cancer that specifically predicts side effects from one type of radiation versus another, which lets people choose the safest path. We have a test that looks at side effects from immune therapy, which, if any of you have considered that or know about it, there are a lot of side effects from that treatment. And it's not everyone, but some people just have bad responses. And then we have a test, actually, our first finding was one that actually really predicts cancer risk for women, although it's not uncommon in prostate cancer patients as well. And that was the beginning of our understanding of this class of genetics. So I'm going to go into radiation and some of the side effects from radiation at this point to explain the basis of that test. So radiation, I always tell patients, so I do treat patients with radiation. I treat breast cancer. That's my current focus. As I said, as a radiation oncologist in training, you really see everything, and I've certainly seen a fair number of prostate cancer patients. But as things have, advanced since I graduated way back in 2024 from, 2004 from residency, we have really improved in making radiation something that, because it's so focused, we could do much more quickly. So when I was a resident for prostate cancer, we treated people for 8 to 9 weeks, 5 days a week. So it was a full-time job. I mean, people would come in, put aside their life. It became kind of their job. It was only an hour a day, but they had to come in every day for 5 days a week. That's called conventionally fractionated radiation. And we really developed radiation that way because we knew a tumor cell would be more sensitive than a normal cell if we gave radiation in tiny little pieces. Like over time, a tumor cell couldn't fix itself, so we'd get rid of the tumor cell, but a normal cell would be able to manage that level of damage. But as we've been able to really focus radiation and focus more just on the tumor area, we've found that we can give much bigger doses of radiation and many fewer fractions. So instead of 2 gray, that's a dose for 35 treatments, we can give 7 gray in 5 treatments. And that turns out being really a very safe approach. And of course, it is incredibly more convenient for a patient. You can come for a week, 1 to 2 weeks, and be done. So it's almost equivalent to taking the time out from surgery for prostate cancer. You could be done with radiation in a week and a half. So obviously there are great advantages to this approach. Now, the challenge is there are side effects from radiation. There are side effects from surgery. So for prostate cancer, which you guys are, some of you, it sounds like you're earlier stage, but you're probably aware and have read up and learned about options for treatment if the time comes. We have our side effects from surgery, and we have our side effects from radiation. And they're similar in that a lot of the most common bothersome side effects are urinary side effects. And, the ones that you have from surgery often are from having to cut the urethra and sew it back together. So there's a lot of hesitancy, incontinence side effects that's the risk. For radiation, you also have urinary side effects that can be really bothersome if someone gets them, where it's, discomfort or pain with urination, frequent urination, or lack of emptying. There can be some incontinence, a little less common, but real urgency where that's a problem. And, we grade side effects, with a grade 1 being pretty mild, grade 2 really being bothersome. Grade 5 is the most severe. It's grade 1 through 5. 5 is actually death. We don't really cause, thank goodness, generally with radiation to the prostate. But grade 2 are bothersome. They affect your quality of life. You might need to have medication to manage it. You might need an intervention to see if you're bleeding, or you might have a stricture, and things need to be addressed surgically. So interestingly, I always tell patients that are getting radiation, there are a couple different types of side effects. There are side effects you have during radiation, and there are side effects that you actually don't have any side effects. Then all of a sudden, like 9 months, a year out, you start really having side effects. Sometimes people will have bad side effects at the beginning that don't go away. That's called chronic toxicity. It's less common. I won't really talk about that today, but there's short-term side effects and there's the late side effects. And I would say, I tell my patients, really, you might have a hard time during treatment, but we'll get you through it and then you'll be fine. but it's the late side effects that are more worrisome because we don't know they're building up until people become symptomatic with them, and then we can't really make them go away. So there's been something going on since the beginning since they got treatment. So the risk of these side effects of grade 2 or higher side effects is pretty high. It's about 15 to 20% for patients treated with radiation. And I'll show you this nice figure. So the good news is most people are at low risk of getting urinary side effects from radiation. These are late side effects that will be bothersome and ongoing. But what's even better is that, I mentioned there are two types of treatment. There's a short treatment, SBRT, or a slower treatment called conventional fractionation. Almost everyone, it's safe for them to get one of those two forms of radiation. But right now, people come in and they don't know what type of radiation to get. They'll say, okay, this one's more convenient, but doctor, what do you think? Oh, I'll come for the 6 weeks, that's okay. Or, oh, I really have to be done in 5 weeks. And they don't know if there's somewhere where both types are safe, or if actually there's one that's safe and the other's not safe, since we see that in a fair number of people where they might be high risk to conventional fractionation, but actually the 5-day is safe, and vice versa. And it's very rare, but 1 to 2% of people actually are really at high risk of that sensitivity to radiation with either. The good news is surgery can still be an option for those patients. Our side effects from radiation don't predict side effects to surgery. So this is the test that we have that predicts these side effects is called Prostox. As I mentioned, it predicts late side effects from radiation. It's been a long road. You mentioned you've heard about the test for about 4 years. We started with study actually in 2020 is when this started enrolling the study of SBRT. We've had a couple validation studies yet. Since then, we just published one this year, just showing even with the highest technology, this still predicts toxicity. And then, who should get this test or who is a right test for? I'd say someone with prostate cancer that's considering radiation to the prostate. And we do have a study suggesting that even if you've had the prostate removed, if you're considering SBRT, which is usually on a trial, in the postoperative setting, actually the signature will also predict it. And if you're considering either SBRT or the conventional fractionation, the Prostox could be useful information for you. And then, how can you get it? We really wanted to make sure Prostox was available to patients. We developed this through the company. It was through clinical trials. It was being offered through UCLA. We had other kind of thought leaders in radiation oncology who were doing a lot of SBRT who could help us, decide the best way to offer this to patients and what to do with information. That is through MiraDx and kind of select clinics. But about 1.5 years ago, we actually opened it also through MiraKind. So I started a nonprofit in about 2015 to allow patients themselves who wanted genetic information that were like, this could be useful for me, wanted to make sure they could get the test. And I guess maybe some of you have accessed it that way, which I think is great. What we hope is that someone will, by ordering a test through MiraKind, I want to work with you to learn from you. So that's the whole purpose of MiraKind, is to kind of learn from patients. So we ask that patients get the test through MiraKind, that they join a registry so we can get feedback. Was it useful? How did things go for you? Other health things from you. And these are, as I mentioned, some of the clinics that do offer the testing. There's UCLA here, but we have them kind of across the country. And that number has been growing. It's actually really easy in the lab if anyone wants to know. The nice thing is, because what we're testing is a new type of genetics where it's in all your cells, we can do a cheek swab just of your collect cells from basically a cotton swab, which is very stable. There's some special media that you put it in, but that can be mailed to you as a patient and then returned. And then it's kind of quick 3 to 5 day turnaround. That your DNA is taken out of that swab. A bunch of markers are tested to see what your genetics looks like in these important areas of the DNA we study. We put it through an algorithm and come out with a score that, this radiation is, you're at high risk of toxicity or you're at low risk. And that's the report that we share with the doctors that kind of split it just into two. We have a lot of people that have done this, and the feedback has really been that it's been helpful and informative. But I'd love to answer any questions people have. And I think that's where I am.
So what we'll do here is ask that you type your questions into the chat box up in the upper right. I'm going to take a moderator's prerogative and start with two right off the beginning. Have you had people who have not been tested initially, who developed complications or side effects later on, come back and say, I'd like to see if my genetics may have something to do? So have you had anybody come at the time of the side effect looking for
I
these?
have through MiraKind, and I would say actually some of the clinics when they first started, they're like, yeah, I was really puzzled by this case and I want to test it. And we do that as research from the clinicians if they want to do it. They're like, I want to get insight because I have searched that person's plan. I cannot figure out why they had toxicity. And I know that some are like, and that actually really convinced me that this test means something because I was really stumped on that one. Like I couldn't figure it out. So we've had some doctors do it that way. And I've actually have started letting some patients that either just had treatment and they wanted an insight onto, should I be watching out for this? Part of that is getting our study going because I want to kind of understand if you did have side effects, to try to get a better insight into what your treatment was. It's a little hard sometimes if it's from a patient because radiation is a weird field where, of course, we speak a language that no one speaks. So, people say, I did an SIB boost to the, 2 millimeter margin around this and blah, blah, blah. And it is not English. I mean, I kind of get it, but so sometimes it's hard without that additional information. And but I'm always, I'm open to it, particularly as we're starting to open up our registry to allow patients. There's a question, I think, but I don't get to, I'm
Yeah,
not clear.
I'll read through them. Let me ask my second, and
Go
that
ahead.
is there any correlation between these genetic findings and brachytherapy with HDR or LDR?
Perfect question. I think there will be because I think LDR is similar to conventional fractionation and HDR is similar to SBRT. We have studies ongoing looking at that because a lot of people do get brachytherapy. When I trained, we only did LDR, permanent seed implants, and it was very convenient for the patient and a great treatment choice. And so we actually have an ongoing study with a group they do a lot of permanent seed implants where they're building their registry. We're testing patients. We'll run it to see if it's conventional fractionation signature or a different one. And then actually we're in conversations with a group about an HDR study as well, because I think that's an important treatment option for prostate cancer patients. It would be important to see.
So Rick asks whether there's, what's your view on certain mutations, especially HRR, BRCA, and does that make you more sensitive to radiation therapy? One, from the standpoint of the treatment or for side effects, and I guess other radiosensitizers might fit into that question as well.
Yeah, no, that's a great question, and something we talk about in breast cancer all the time. So, they do studies and they claim or they say that, a BRCA mutation, which is we see in prostate cancer too, right, doesn't make you more radiosensitive. Like there have been big published studies saying there isn't radiosensitivity. And we're seeing ATM mutations too, ATM mutations, patients that are ATM, heterozygous for ATM in breast at least. And they are, of course, DNA repair mutations. So people should be more radiosensitive. I mean, their tumor should be especially radiosensitive because it's loss of normal allele, right, of BRCA. So I would say what I've observed in patients is I think they're a little more likely to have short-term, that acute toxicity, because short-term toxicity is a lot that's really related to DNA repair. And actually, we even have genetics predicting acute toxicity, and it is about DNA repair because it's your immediate response. You're trying to fix your DNA, and if you don't, the cells are damaged. The late toxicity we see is actually not about DNA repair. It's much more about it's immune genes that we find in that signature, and it's about uncontrolled inflammation to explain it. That's what I think happens. Something set off and it just never settles down. And but I think that people with, BRCA mutations are likely going to be a little more sensitive to, in the short term, to radiation, but it should resolve. But I don't think they'll be more likely to have toxicity in the long run. Those are not part of our panels, actually, but we certainly tested patients with those mutations. Now, that's something that will be, they're obviously rare, or, not incredibly rare in prostate or breast, but something that as we build our database and we build our registry, that's information for us, because something we'd like to continue to consider for patients.
Okay. We have a bunch of guys who are using radioligand therapy. And what are you working on and looking at in regards to that type of therapy?
Yeah, we are studying radioligand therapy, actually. Super interesting area. Actually, the company approached us a couple years ago about our markers and radioligand therapy. My experience for the last, since I started, we started trying to talk to pharma, really trying in like 2017. In general, pharma is interested in markers that help expand their treatment population, but they really don't want to hear about things that cause toxicity because they might lose patients. And radioligand, it sounds like there's some blood toxicity, but not a ton of toxicity, although, obviously I haven't received it and I don't deliver it. However, we do have a trial. We had a trial at UCLA. We were submitting it for the ASTRA meeting and for publication, looking at radioligands in combination with focused radiation to look in someone with a limited number of metastatic sites where they radiated the sites and were randomized to get radioligand or not. That will be a different signature. We do have toxicity. We haven't looked at that yet, but we're looking at actually genetics that predict a good response to that. And there are some genetics which make sense. In general, it was really good for everybody. In general, patients benefited and had longer progression-free survival if they got the radioligand. It's obviously a great therapy, but we're just looking at toxicity in that data set.
Okay. If we have more questions and people would like to type them in, that would be great. I'm wondering if either the type of radiation delivery, photon versus proton, that's a battle that many advertising dollars are out there trying to sway opinions. Do you have any insight from looking at this and side effects in that population?
Yes, great question. You're asking all the great questions. So I think this signature applies regardless of protons or photons. There's obviously so many battles about that, even within the field, because people invested hundreds of millions of dollars building these proton facilities. And it's very targeted. And I would say I believe protons are better for certain things, but there's not been a proven cancer control rate or decrease in toxicity in prostate cancer or breast cancer. But in certain cancers, for pediatrics, I think protons are very meaningful. For certain spinal cord tumors, being that focused is meaningful. But I would say, the argument that protons are better is all about controlling where the dose is dropped off. I would say the toxicity we're predicting is about from hitting the prostate, which is the target, right? So it's not off target effects. Even an MRI machine, which is very targeted, the patients that were high risk for Prostox still had toxicity. So it's not about hitting the bladder or hitting the rectum or hitting other things, which really is the argument for protons, that you're controlling the drop off, the Bragg peak. So where you dump the dose, but it's the prostate tissue itself, I think, that gets fibrotic, and you have to treat it because that's where the prostate cancer is. And the urethra passes through it. So if it fibroses around it, it's going to cause a lot of urinary symptoms. That's my belief in how it works.
So Dr. John Antonucci asked whether, based on this information, you can proactively adjust the dose, which may reduce that toxicity. In other words, are we going to have a nomogram that would say, this is your Prostox score, do this to your dose?
Well, I mean, the great thing is that at least if I would say the way UCLA has used it is people come for SBRT to UCLA from everywhere. And if someone is high risk on Prostox for SBRT, they've given them moderate hypofractionation. And actually it works pretty well because only about 7 to 8% of people will be high risk to toxicity from conventional, which is less than average. So they use it to adjust their treatment plan versus the actual number of doses. And that's a question. I mean, one thought is, oh, what if we spread it out? If someone's Prostox high risk, those are sensitivity to the big doses. What if we do once a week instead of every other day, right? And I would speculate that it's actually, the response to radiation to that big dose, you probably set that cascade off. I don't know if you need all 5 doses to get there. We know if you give a smaller dose, we know the response is different. The biological response is different. That's why I think the conventional is safe for a lot of patients.
Okay. And what about availability of Prostox in New York? For a while, I think it wasn't available.
Yeah, you know what? We actually have done, between us, we're all friends here, right? We've tried to suggest people just don't have their test mailed to New York, but we do let people join by research. But we did just have our New York State inspection. So hopefully, it's not us, it's New York, doesn't like the people that live in New York to get tests that unless they're here to examine you. We did have a very positive New York inspection a couple weeks ago. So we should, with very minor nothingness to fix. So we're hopeful that we'll have our official New York certification sometime. I don't know how long it takes, maybe a month, and then there'll be no problem getting New York tests.
Have you been able to see any difference in those patients who are on ADT or not? Is that a factor in these late side effects at all?
It's a good question. We did look at that. It was considered in the Mirage trial, but it didn't end up being a significant, wasn't part of the final model. It really was the genetics. Nothing strengthened the genetics, not even any of the treatment parameters, but none of the patient parameters either. So even size of prostate or starting urinary score, none of that impacted that risk. And ADT was one of those variables, but we didn't see it is impacting it.
Okay. Len Sierra asks if one has already had primary radiation therapy and they're coming back for spot radiation therapy for a recurrence, or they had surgery and now they're getting radiation on the prostate bed. In managing the recurrences, is Prostox useful in that setting as well?
Good question. So in some situations, so we did look at the Prostox SBRT signature, and we looked at a group of patients that got SBRT after surgery, which is done on clinical trial. Usually if someone's recurred in the prostate bed after surgery, they do conventional fractionation. We tested a group. We said, okay, we've given SBRT. We'll use the SBRT signature if you're getting SBRT to the prostate bed. And it did actually hold up. So it does work in that setting. So Prostox SBRT, Prostox Ultra, we call it, works in the post-op setting if they're treating the prostate bed. If they're treating by any means a lymph node in the abdomen or a bone met, we don't know what it would mean. I mean, we're predicting fibrosis. Would you be symptomatic if it was in the leg? Probably not. So it's probably not meaningful if it's a different place you're treating. We haven't yet tested a post-op conventional fractionation, which is how most people are treated. We are working with a group in the Netherlands, I think, somewhere, because they have a cohort where they actually have samples and they want us to test it, and we're jumping through the hoops of the regulatory things to get those samples, because I think it would be great to see if our Prostox CFRT also works in the post-op setting. So yes, in development, and probably not if it's not the prostate bed.
So that's all the questions I have on here now, but we can keep on going if that's all right. I wonder if you might talk about what you see in the future and what this type of way of looking, rather than just finding targets to treat, but finding ways to evaluate either the effectiveness or the risk of certain treatments, genetics may open up to. Are there other areas other than the prostate where this has been applied and you think it might be useful to validate?
Sure, absolutely. So there are several different cancer types that we've applied this to for radiation. So breast cancer, sarcomas, rectal cancer, many things, where I think we can look at side effects to help with that decision. In certain cases, we could look at, will you respond to this treatment? Is it better to do big fractions versus small? Is radiation a good path for you? And then we do have a test for immune therapy and immune therapy toxicity. And that's really across cancer types. But I think the general idea that trying to look at a patient instead of just their tumor, trying to consider toxicity as well, those two things are kind of new, right? So the patient genetics and how they will respond or have side effects, as well as actually really trying to look at side effects as part of the treatment decision. I really hope that's the way of the future. It's been not out of lack of desire, but I think we haven't had the tools. This new understanding of genetics gives us a lot of answers we just haven't had. So I'm hopeful everyone will jump on this bandwagon.
How do you advise you don't advise the patient directly at that stage, but today I was talking to some fellow and recommended Prostox as part of the considerations to ask the radiation oncologist about. And the response they get, and this is often the same with many newer therapies, is I don't believe in it. I'm sure you've heard that a lot, and I'm wondering how you respond. And other than, ask more docs, get more opinions, how might that be something that's addressed?
Sure. I mean, a lot of that has been, I have kind of been very thoughtful about, like, we haven't done a big push. I mean, MiraDx is a company, but I'm a cancer doctor. And, my goal has been, let's get smart people that treat, radiation oncologists that treat prostate cancer to use the test and see what they think. There are so many different things we could develop and offer to patients. I'm hopeful it's useful for the patient. I want a doctor to be comfortable using it. And until that time, it's our responsibility to cover the cost of it. So because of that, we've done a very specific kind of partnership with physicians. We have not done a big push to get all physicians to order this test. We just completed our validation study, and we're getting to the point, and we're working with insurance, which of course is the big bane of everyone's existence, any company's existence, to cover the test for patients, because they should, because it helps patients, and in the long run will save them money. So as we're rolling that out, the plan is there's been a big increase in awareness just because of the validation studies, and the clinics that do use the test are kind of thought leaders, so they talk about it. So awareness has been growing. It's been very grassroots, which I kind of like grassroots. I'd rather be word of mouth. And I appreciate that the patients are actually our spokespeople. I'm interested in this test. That is why we have MiraKind, because I want to make sure you can get it if you want it. and not just because your doctor hasn't read up on it, right? Um, so
One person asked whether if I made you presenter again, whether you have a slide of the report that you can just review with us.
sure, I can. It's in my slides. Yep. Now we've updated the report a little bit, but I'm happy to walk you through it.
Wait, I got to make you presenter again here.
You have to
And
allow me.
and Joanne, whilst you're pulling it up, I just want to tell you that we have at least one gent that I know of in the group who changed his treatment based on your test.
I'm
He,
glad.
he wanted to do SBRT and he did a Prostox, and the doc said, I don't think you're a great candidate. I think we should do IMRT. Would you like to speak up and thank Dr. Joanne Paul? No, I don't know if he's still. I don't know if he's. I
Well,
don't.
that's okay. I'm
Oh,
happy
Don't
that
like put him on the spot or anything, Rick.
No, I won't put him on the spot, but I do see he's there, and he never has much problem speaking up. Are you there, Paul? Would you like to say?
no,
Oh, no, he's probably stepped away. Okay.
no worries. This is what the test looks like. It's evolving a little, so it's a little easier to understand. But we basically, for the physician, just break it into high risk and low risk. And someone that's high risk is about 7 to 8-fold increased risk of toxicity. So it's about 80% chance versus someone that's low risk, where they're about a 5 to 7% risk of this late GU toxicity.
My understanding is that if someone had placed on a medicine like tamsulosin, that gets them to be considered a grade 2
Yeah,
side
it's
effect.
a great question, right? So grade 2, when we first developed the test, we used RTOG grading, which didn't include, that's not grade 2 if you're on Flomax. But in our validation in Mirage, grade 2 is okay, you need to go on Flomax, and that's new, right? We actually, what we do find, which is important, is that someone high risk is also at higher risk of grade 3 toxicity. So grade 3 is really bad. Like no doctor wants a grade 3, no patient, certainly no patient wants a grade 3, but a doctor. So normally a risk of a grade 3 toxicity is like 2 to 3%. It's really low, but with a high Prostox, it's like 12 to 13%, which is really unacceptably high. Like nobody wants that. Like it's not a big deal to have a grade 2 toxicity for most people. They'll be like, blah, blah. But the higher the Prostox score, actually, you see increasing risk of both grade 2, but also grade 3 gets up there too. So, yeah. So,
And is there a relationship between the GU toxicity and GI toxicity?
that's a great question. Gosh, you're full of them. No, it's actually
They're
like
not all mine. I get to sound smart because
okay,
our group
group has great questions. Group, you have great questions. No, it looks like they're different signatures, and I'm not surprised. I think GI toxicity is often probably damage or thinning of the lining of the GI tract, and there's bleeding. The GU toxicity is more fibrosis. So GI might be similar to like if someone has a lot of bleeding from the bladder, so hematuria, which is fairly rare. But it's different than what Prostox predicts the GU toxicity. We've always seen it's different, and GI toxicity is fairly rare, fortunately, particularly with better targeting, because that really is about hitting the bowel, right? So it's a high dose to the rectum, basically. So.
And we had another question asking about heavy ion radiation treatment and any input or information about that.
That will likely be a different signature because I do think the mechanism, it creates a lot of DNA damage. I have little experience with it, and I have no samples of patients treated that way. I'd always be interested in looking at it. I'd be interested to see. I think it would be a different genetic signature because I think biologically the response is quite different, actually, than photons or protons.
And any response or any information regarding genetic evaluation and susceptibility and the various focal treatments that are out there?
Yeah, it's a good question. So there is definitely, we do a lot of brachytherapy at UCLA. Oh, are you thinking like cryoablation?
Cryo
Yeah.
or IRE, or we've had a couple of people who've had IRE here.
Yes, I
Tell
don't
us
know.
that.
I mean, the truth is that it's a really small area usually being targeted. And there is some interest in someone that's high risk for Prostox. Oh, what if you did like very focal ablation of the high risk
Right.
area? Now that we have such good MRIs, maybe it wouldn't bother you if just part of the prostate, if it's far enough from the urethra, maybe that would be okay. Right. So there's certainly some interest, or sometimes they'll do very focal brachytherapy and maybe part of the prostate is still okay. So we certainly have some of those trials ongoing at UCLA.
Okay. Let's see. If someone who's got their phone on or background noise, if you can all mute yourself until you're called upon, that would be great. Tim in Tampa, you had a question.
Yeah, I just wanted to tell the Prostox people that I'm a Prostox patient, thanks to Dr. Mark,
Okay.
back in July of last year. And I was low risk for SBRT and CFRT. And I just wanted to tell you that the whole process was very smooth, painless. And I worked mostly, I think, through calling and emails with Kyle.
Yes, there she is.
And hi. It went very well, and I just wanted to give that positive feedback. And I'm 5 months out of SBRT, by the way, and things are going pretty well.
Good. That's wonderful.
So thank you.
I was also a Prostox.
one
I'm
other
also
thing.
a Prostox client, and I had a similar thing.
I'm with Moffitt in Tampa, and I'd like to think that I was the first and only time or patient that they've ever seen Prostox with, just for your information.
You know, they've started testing. You might have been the motivator
It might have been it.
because they've actually reached out and they're set up, and we are doing our research study on HDR with them.
Well, thanks for that. Thanks for letting me know.
Yeah, I thank you.
Okay.
Nick,
Well,
Nick,
that's great.
Nick Lagos, you wanted to say something.
I don't need to interrupt. I also was a Prostox client, am a Prostox client like Tim, and have also had a very smooth experience with it.
Awesome. That's great.
See, we're trying to put the word out here, Dr. Joanne. We're trying. We think you've got a good product, and and I would like to say we're going to have to stop pretty much because we've got a regular group about to start, which you're very welcome to stay and listen to the group. But if there's any way that we can work with you, we can help you. We're eager to do it, and
Amazing.
we're eager to put our badge on your website and
Fantastic.
whatever.
Judith is head of marketing, and she may follow up with you on that. Because I will tell you, when we started this, I was like, we need to get stuff to patients. That's my heart is with the patients always. And then I did this 1-year business program. I'm like, okay, I can't only have it for patients. Doctors need to order it. Insurance needs to pay for it. So, but it always has to start with, it's about the patient. So.
Well, that's great. Do you have any final words, Rick, before we stop the recording?
No, I don't think so. But if we've got any questions that we want to follow up with, we know how to get hold of you. And we're just very grateful. Thank you so much for coming on and spending some time with us. And we hope we can keep making a difference for patients by encouraging them to get the Prostox test. So,
well, lovely meeting you all. Feel free to reach out anytime.
Thank you. Thank you. I'm going to stop the recording right now, and then we'll restart it in a few minutes. There's a lot of people giving you claps in the